My first, shall I start, sir? Yeah, my first short case is Mrs. Sharada Bai. She is 60 years old female patient, resident of Vikarabad, not formally educated, farmer by occupation, admitted to the hospital on 12th of August, examined on 18th of August. Informant being self and son, 60, sir, 60. A patient presented to the hospital with chief complaints of abdominal pain for 15 days, fever for last 15 days, hematuria for last 4 days, decreased urine output for last 2 days, and breathlessness since last 2 days. Coming to the history of present illness, I would like to date back my history 3 months back when she started complaining of abdominal pain in both the flanks, which was insidious onset, gradually progressive, dull aching in nature, non-radiating, which was not aggravated, or there were no aggravating or relieving factors for this. Patient visited to the nearby hospital with these complaints, where she was given some analgesic and advised to undergo USG abdomen. She underwent ultrasound abdomen, and after scan she was told to have she is having large kidneys with multiple cysts in both the kidneys and liver. At the same time, she was also told that she is having high blood pressure, which is around 170 by 100 millimeter of mercury, and which was treated with some antihypertensive medicine, which she doesn't remember. Name she doesn't remember. She does not remember any blood investigation report or any blood investigations done at that time. She was advised to follow up with the nephrologist at this point of time, but she did not comply and lost to follow. 15 days back, when patients started complaining of abdominal pain in the right flank, which was insidious onset, gradually progressing in nature, diffuse and throbbing in nature, more in the right flank, non-radiating, which was associated with abdominal distension, and there was also history of early satiety. And she is also complaining of fever for last 15 days, which was low grade, intermittent, associated with chills and sometimes rigor, which subsided with the medicine, over the counter medicine, which she took nearby home. She is also having history of nausea and vomiting for last 4 days, which is non-projectile, non-bilious, non-blood stain, containing food particles. And also there is history of hematuria for last 4 days, which is painless throughout the micturition, which is not associated with pain or any clots. She is also telling that she is having complaints of decreased urine output for last 4 days, and breathlessness for last 2 days, which is NYHA grade 2, which has progressed to grade 3, which is not associated with any orthopnea or P&A, and not associated with any chest pain, cough or expectoration. She does not give any history of burning micturition, frothy urine, graveluria, or any pedal edema or facial puffiness. There is no history of urgency, urinary incontinence. There is no history of loss of appetite, weight loss, or any yellowish discoloration of eyes or urine. And there is no history of any alternate medicine used in between. With this complaint, she came to the hospital. During the course of hospital, she was admitted, and she was told to have there is some infection in the kidney, and she is having high serum creatinine level. That was she remembers as 8 milligram per deciliter, and for this she needs hemodialysis with some blood transfusion. Patient underwent till now she has underwent 3 sessions of hemodialysis through right IGV dialysis catheter on 12th of August, 13th of August, and 15th of August. With 1 point of PRBC she has received, 1 point of blood she has received during first session of hemodialysis. Coming to past history. Patient is a known case of hypertension for last 7 years, which was diagnosed on routine evaluation, and she was advised for one BP medication, 1 tablet 2 times a day. For she is having poor compliance. There is no history of diabetes mellitus or any coronary artery disease or any CVA, or previous history of any infections like tuberculosis. There is no history of any major surgeries in the past, except family planning, tubal ligation 38 years back she underwent. Coming to personal history, she is taking mixed diet, and also she is having addictions of toddy drinking every day, around 500 to around 1 liter per day for last 20 to 25 years. She is having no history of any smoking or tobacco chewing, and there is no history of normal bowel habits and sleep. Coming to menstrual history, she is having she attained her menarche at 14 years of age and menopause at the 40 years of age, and there is no history of any postmenopausal bleeding. She had coming to obstetric history, she had 3 normal vaginal deliveries at home with no formal ANC visits. And coming to family histories, she's she's having 9 siblings. Out of 9 siblings, 6 siblings have passed away, with 1 sibling having 1 younger sister is having some kidney issues, and she is undergoing dialysis for last 3 years. Her parents passed away with when she was very young, and the cause of death she does not remember. Medication history, she's taking antihypertensive medication, 2 tablets per day, name she doesn't remember, and she received COVID vaccination, 2 doses she has taken a year back. There is no history of any allergy or any allergy to any medication. Summary. Yes, ma'am. On examination, patient is conscious, coherent to time, place, and person. She is moderately built, averagely nourished with. Her BP is on the day of examination. Her BP was 130 by 80 millimeter mercury, and right arm supine position with pulse rate of 90 beats per minute, regular, ma'am. In systemic examination, there is abdomen was distended with bilateral lumbar region mass filled, which was palatable and moves with respiration and irregular consistency. That was the only positive finding, ma'am. Abdominal distension with palatable mass in the lumbar region, sir. Yes, sir.
Describe that mass.
Yes, the mass is irregular in consistency, which moves with respiration.
How will you describe a kidney mass?
Ma'am, any kidney mass, we have to on inspection we will see the surface.
Least palpation.
On palpation, no, sir.
No.
Abdominal mass.
Abdominal mass.
Sir, on palpation we will see the consistency of the surface, and
First of all, size of this mass, isn't it?
yes, ma'am. Size of the mass, then consistency of the mass, then margins, any movement with the respiration.
How can you differentiate it from a liver mass? Right renal mass from a liver mass. Can be huge hepatomegaly coming into the right iliac fossa, isn't it?
We won't be able to reach to the upper limit of the liver, ma'am. Whereas kidney masses we can.
Will it cross to the opposite side, cross the midline?
No, ma'am.
Isn't it?
To know about the abdominal examinations, right? So how you can go and reach define upper margin of the liver is in this intercostal region, and also there are different way of examinations. You should go on doing the percussion and see. So that is important. Then you should go on palpating the lower margins can be felt of the liver. So this is below costal margin, how much fingers it is below the costal margins. then you can explain about the liver surface, then see about the tenderness of the liver. Definitely then you have to go for the examination of the kidney. Normal kidney, if you want to examine, how you examine whether this is palatable or not, how you do this.
How will
So
you
these are all the
differentiate
bedside
left
techniques.
kidney from a splenic mass? This is third year MBBS questions, not DM nephrology question.
Man, spleen, the growth of spleen usually is towards the midline of the umbilicus, ma'am. So,
Direction of the swelling.
yes, ma'am, direction of the swelling.
Mm.
And spleen surface is usually smooth, and
Splenic notch.
there will be splenic notch present in the spleen, ma'am.
Kidney move with respiration.
Yes, sir.
Is it retroperitoneal or intraperitoneal?
Retroperitoneal.
Retroperitoneal organs move with respiration.
Yes, sir.
All retroperitoneal organs.
Kidney moves, spleen doesn't move, sir.
Spine being retroperitoneal.
there is-
when it moves. Why?
Sir, sir, there is a linorenal ligament. I'm not sure.
But it does move, as you might have seen when you do a biopsy.
Yes, sir.
You see the liver goes like this.
Yes.
When you are palpating the abdominal mass from this level, you can get above the mass. Okay, if you can get above the mass, that's actually largely there's something above it's coming, something in the liver and the spleen. Okay?
Yes.
So you can get above the mass. If you are able to get above the mass, then actually it isn't something down. So it is a top down level that is something.
So after finishing this examination, what mass you are taking of, what kind of mass it is? Is the mass originating from the liver, originating from the kidney, it is originating from the spleen?
Sir, actually this mass is bilaterally felt, sir, and
Is the surface smooth or irregular?
irregular surface.
By this irregular surface, what you want to convey?
Sir, there may be
Please use the mic.
sir, with this irregular surface underlying some irregular growth or development, we can felt, sir, that of the mass. So,
What is this mass?
What is this mass?
sir, this mass could be coming, this kidney mass coming from maybe irregular development of the cyst of the kidneys, sir.
Polycystic kidneys.
Yes, ma'am.
So आप बताओ ना bilateral it is looking like this irregular surface of this kidney, and so it is probably the originating from the kidney, so it is looking like ADP kidney or polycystic kidney. That is polycystic kidney it is looking like, whether this is dominant or not you cannot say, but that much you can come out. This is the DM level examination, not the MBBS level examination, so you do not know.
The liver was not palpable in this patient.
No, sir.
I'm asking because you had mentioned earlier that the ultrasound showed cysts in the liver.
Yes, sir.
What is the importance of looking for cyst in the liver when you see cyst in the kidneys?
Ma'am,
This is a 60-year-old patient who can have simple cyst also, isn't it?
yes, ma'am.
Few of the simple cyst can happen.
Ma'am, presence in the cyst in the liver in a patient with ADPKD, there are more than 90% of the patient will at the age more than 50 years will present as cyst in the liver, ma'am. As the
Give a diagnostic clue that this is polycystic.
yes, ma'am, it gives a diagnostic clues towards
There is no
polycystic.
prognostic significance, but it is diagnostic clue for a polycystic.
Yes, ma'am.
Supports the
Yes, ma'am.
If you want to say this in Hindi, you should always use the terminology. That is the better term.
Yes, sir.
Something like that, but use whether they are there or not. So that probably gives you more in favor of something like a people where you are more comfortable in seeing. Otherwise, any other mass.
Yes, sir.
Very fast and renal malignancy also probably you can feel that it must be renal mass. So malabsorption is one feature, something like that. While description itself you should complete in one sentence. That you should, you are given the indirect link that it's a KP or directly.
This patient had abdominal pain as well.
Yes, sir.
What are the types of pain originating in the urinary tract, in the upper urinary tract?
Sir, pain it usually located to in the lumbar region or in the flank region is more likely coming from the some PUG obstruction or
यूजली ऑब्स्ट्रक्शन इतना बड़ी देखा कभी पेन देखा बताता है क्या यूजली
Usually that is asymptomatic most of the time. My question was simple, very basic. What are the types of pain which originate from the kidneys or the upper urinary tract?
just describe how you describe pain whenever any patient complains of the pain abdomen. So there are certain characteristics of the pain that indicates I am colicky, non-colicky, dull aching, quadrant, which quadrant associated with some other symptoms, है ना? So you should describe about all this.
Yes, answer the question
Yeah.
for you.
yes.
Yeah, just giving you should describe in this way because you are presenting any patients with a very obvious mass of in the abdomen, है ना? So you should describe. You should have all description in your history and examinations. Tell us.
Sir, colicky pain originates from basically from the ureter cell due to obstructions.
And can you describe a colicky pain?
Sir, colicky pain is severe pain which is patient will complain like something that is twisting.
Is it intermittent? Is it continuous?
It is intermittent in nature, sir.
Intermittent. Sure.
Continuous.
Typical description is continuous and crescendo in character. Means it's a continuous pain which
Increasing.
increases and then it may suddenly go away if the obstruction gets relieved. Or you give some drugs, it may suddenly. So it's not an intermittent pain like other colics may be intermittent. This one is continuous and crescendo. So that is one kind of pain which is common. The other kind of pain which is more likely to have been there in this patient,
So there can be throbbing type of pain, sir, when
dull
the aching pains.
which is just results from stretching of the renal capsule, enlargement of the kidney, which happens in ADPKD also. Any other causes of this kind of pain, dull ache?
It can be secondary to pyelonephritis.
Yes, acute pyelonephritis, that's right. So that would be the typical example where you can get a dull ache, you won't get colic. So
Can they
these
have
are the two types. of-
stones and cause pain? Polycystic kidney? Kidney stones?
Yes, ma'am. Renal stones, kidney stones in the ADPKD can cause a pain, ma'am.
Can you have cyst hemorrhage and cause pain?
Yes, ma'am. Cyst hemorrhage also can cause
These are the
pain.
various causes for pain in a patient with polycystic kidney.
Cyst infection.
Cyst infection, cyst hemorrhage, or stones in the kidney.
What are the differential diagnosis if they present with hematuria?
Ma'am, patient presenting with hematuria, this can be secondary to cyst infection or cyst hemorrhage or because of renal this stone which can lead to this or malignancy in presence of cystic disease. Ma'am.
What are the types of hematuria in general, not specific for polycystic? How do you classify hematuria?
Sir, hematuria can be three different way we can tell, sir. When it is there is hematuria at the beginning of the micturiation, sir,
Yes.
then this can be secondary to lower urinary tract injury, or when it is throughout the micturiation, sir, it can be the origin can be above the bladder or from the kidneys, or when the hematuria is at the end of the micturiation, this the possible injury can be from bladder, sir.
Yeah. So initial, total, terminal.
Yes, sir.
Those are the three types of
Yes, sir.
gross hematuria that you can have. That's what
Yes,
we're referring to.
So what is your diagnosis?
Sir,
Examination.
So then tell us about your diagnosis, provisional diagnosis.
so my provisional diagnosis in this case is acute kidney injury on chronic kidney disease, sir. The chronic kidney disease could be secondary to this adult onset polycystic kidney, sir. Whereas acute component can be secondary to urinary tract infection or
Adult onset.
cyst.
What is this adult onset?
What is the full form of ADPKD?
Autosomal dominant, sorry. Autosomal dominant polycystic kidney disease.
Ah, yeah, tell.
Sir. And this acute component could be secondary to urinary tract infection or cyst infection, or and there is cyst hemorrhage suspected, sir, in view of hematuria.
So, urinary tract infections, you are thinking of the cystic infection or simple cystitis?
Sir, cyst infection, sir.
Cyst infection. And then
Cyst
more
infection.
cyst hemorrhage. Because the patient had hematuria also.
Yes, sir.
Yeah? Okay. Anything else you would like to add on in your complete diagnosis?
There is associated comorbidity as hypertension, sir.
Hypertension. So usually most of the patient hypertension has prognostic value in ADPKD.
Yes, sir.
So you must tell us when you are completing your examination, completing your history, and then diagnosis. You must add on all the complications which are, if there are evidences on the examinations. Yeah. So associated with the hypertension. Fine. So now you have to approach this patient. Come on this final diagnosis and manage this patient. Yeah. So what will you do? What will be your approach?
Sir, at present patient is presented with
How will you confirm your diagnosis first? You have completed your clinical examination, you have a working diagnosis.
yes,
Now
ma'am.
how will you confirm your diagnosis?
Ma'am, to confirm the diagnosis of whether it is UTI or cyst
First
infection.
of all, confirm that this is autosomal dominant polycystic kidney.
Yes, ma'am. To confirm autosomal dominant polycystic kidney, we'll see the ultrasound. If there are multiple
Those criteria by ultrasound, diagnostic criteria by ultrasound.
modified Revan's criteria, ma'am. In which modified Revan's criteria, if age between
Depending upon the age and the presence or absence of family history, you have this much number of cysts, etc.
Yes, ma'am.
Okay, great.
This patient is 60.
60 years, sir. Yes, sir.
Do you still want to do a genetic study here?
No, ma'am. Patient is already having with multiple kidney cyst along with liver cyst, and there is a history of a family history of one sibling undergoing dialysis at present, and 6 siblings have died of some
When do you think
unknown.
of doing a complete diagnosis, final diagnosis by a genetic evaluation? When will you think of doing genetic study in patients with suspected ADPKD?
I mean, suspected ADPKD genetic, if there is no history, no family history of ADPKD, or there is some sporadic means presentation,
No family
or
history is sporadic.
yes, ma'am. There is or high risk profession, or
High risk population.
with family history with high risk profession like pilot or
Do you want to do a genetic study in the siblings to rule out the disease.
Or in transplant patient, prospective donors, young.
Selecting a prospective donor from the family. Okay.
In these cases, we'll do the genetic evaluation. Ma'am.
What is the type likely genetic variation in this 60-year-old lady?
Ma'am, I'm suspecting PKD1 genetic mutation in my patient, ma'am.
If this
As-
is a 25-year-old lady, what is the likely possibility presenting with G5 type of mutation?
25.
Early onset CKD.
Why you are thinking this is PKD1? Just
Sir, the disease progression has occurred over the period of
Of the different mutation, which is the most common?
PKD1 mutation, ma'am.
80% is PKD1. That is first reason to think in terms of likely to be PKD1. Other reasons.
Why not PKD2?
Sir, patient has progressed, patient is having hypertension and progressed to CKD stage. Average age of
By
presentation in
50 decade of
PKD1 is 58.
What is the usual behavior of PKD2 mutation?
Ma'am, PKD2 mutation usually benign presentation. They will progress slowly towards the
Late
CKD
GDP,
late
7th or
late
8th decade of life.
Roughly 1.5 to 2 decades later than PKD1.
Yes, sir.
That's the main difference.
What are the other genes has been identified recently?
Ma'am, PRK.
PKD3.
3, 4, 5. Other group.
I'm not aware.
Is there any difference in the PKD1 gene mutation itself? Which correlates with severity and rate of
Yes,
progression?
sir. PKD1, if a truncating mutation is there, there is high probability that patient may.
PKD1 truncating mutation, non-truncating.
Yes, sir.
What is atypical ADPKD?
Sir, a typical ADPKD when there is no family history is present.
I wouldn't call that as atypical.
If only one kidney is cystic
And
and the
one.
other one normal or just one or two cysts.
What are the different forms of atypical ADPKD? There are 5 or 6 different groups of atypical ADPKD.
Where you start suspecting the diagnosis of atypicality itself. Sometimes, and that too when you come across it's an elderly person. And only one kidney is involved. Always I would like to rule out other person, right? What are other forms of atypicalities? One is unilateral involvement. The other forms of atypicality,
what is the usual size of the kidney? Usually, very PKD.
Sir, usually kidneys are enlarged, sir. It can go up to 20 centimeter.
As per the guidelines, when will you say this is an enlarged kidney in ADPKD? Less than that is considered as atypical.
Sir, kidney size more than 1.5 times of.
More than 16 centimeters.
16
like polar length.
Yeah, that is supposed to be associated with rapid progression also.
what is HT-TKV?
Sir, height adjusted total kidney volume.
Volume, yeah.
So what is Mayo Clinic classification, stratification now?
Sir, Mayo Clinic classification is based on the height adjusted total kidney volume. This, sir, when there is increase in this TKV more than 1.5 times, they have graded the HTTKV in 1A to 1E. Accordingly, fast, rapid progressor and slow progressor they have classified, sir. When it is more than 1.C, they
Less
have.
than 1.5%, 1.5 to 3, 3 to 4.5,
Yes, sir.
4.5 to 6, more than 6.
Yes, sir.
So 1, C, D and E are the ones.
Yeah.
Yes,
So
sir.
what is the importance of this? Why we have to break our heads on all this?
Sir, when the patient presents with patient rapid growth or more than 1C is
TKV
there,
correlates well with
well with rapid
natural history
decline.
progression.
Yes, sir.
So which observation was the first one to find a correlation between total kidney volume and the progression of the disease. Have you heard of CRISP?
CRISP trial was there, sir, which showed.
So how do you assess the total kidney volume?
Sir, total kidney volume is assessed by MRI evaluation, sir.
So what are the therapeutic options to retard the progression?
Sir, therapeutic options, we have addition of the control BP, sir, with RAS inhibition, and this we can, if EGFR is more than 45, we can give tolvaptan to decline the progression of the disease, sir.
EGFR more than
60, sorry, 60.
60.
In REPRISE trial, what are the lowest EGFR?
Sir, in REPRISE trial, 25 was the
25, yeah.
25 was the lowest.
And what age group will you use this therapy?
Sir, 18 to 60 they have used.
65 years.
So the difference between tempo and REPRISE, you should please read
Yes,
and
sir.
be very careful. You know, the cutoff EGFR lower cutoff was lower, and the age also small. No? That is the importance of REPRISE.
REPRISE trial.
So which is the largest prospective follow-up cohort study internationally in ADPKD?
Sir, tempo.
No. Overture. Overture, no? What is overture study? No, please be aware with that. That's why it's exciting. 20 countries, 280 centers, 3,000 and odd patients. Again, it's all reiterating or re-emphasizing the importance of total kidney volume. So, the initial studies, the total kidney volume, we found it correlates well with the progression only. But this overture observation has given additional importance of TKV. It says that it correlates with complications of the other complications of disease like hematuria, pain, and quality of life and other things. Please read up about overture.
Your history is very complete and inadequate, especially when you are presenting a genetic disorder. You simply said that 9 siblings, 6 died, 1 is on dialysis. Parents died in the childhood. Not a single word about the children. Parents, how they died, at what age, whether they had any suggestive of IC bleed and died, at what age they died, and what is maternal transmission, paternal transmission. Anybody, siblings from the cousins from first cousins from the maternal side or paternal side also you should be able to mention. And the children also, whether they were screened or not, you should be able
whether the sister who's on
Yes.
dialysis had
Whether
an
she-
ultrasound
similar
or not.
kind of a thing. So you never, so okay, by logic, whatever you said, it goes in favor of ADPKD and all. But you did not give the proper diagnosis history in such a way that you are leading the, you are talking about ADPKD. So
Trying to find out.
you did not do that actually. This is a genetic disorder. So you are making a diagnosis through genetic disorder is a very good family history, which you did not even take. You did not even utter about the children. Though 3 normal vaginal deliveries are done. But how many males and female, whether they are any screened or not, that also you did not. And cousins also is important in this. So that you can say which side is actually pointing it out toward. That's vertical transmission of autosomal dominant inheritance. You're supposed to document and demonstrate there, which you did not do that. But cis in the adult, it may not be always autosomal dominant polycystic kidney disease. Okay, if I have to say the patient, my parents died very early in the childhood of this particular lady, then IC bleed. What is the risk of having an hemorrhage? They happen to have a IC bleed and died. What is the risk of having an hemorrhage? Whether you are going to evaluate this lady and other people also for the possibility of a risk of IC bleed?
Sir, in positive family history of patient died with parents died with aneurysm is positive 16%, sir. Whereas in cases it is with negative family history is 6%, sir. So that is also having significance in evaluating.
Can a 10-year-old child can present with cyst due to ADPKD?
Yes, ma'am.
What percentage of pediatric age group presents with cyst in the, with ADPKD?
Ma'am, I guess 3 to 5% patient may present as ADPKD in child.
How will you differentiate it from autosomal recessive polycystic kidney?
Ma'am, autosomal this ARPKD patient will progress faster towards the end stage kidney disease, ma'am. Whereas
Is it?
Just tell me why this is AR, why this is AD. So how you will come on these conclusions?
Both will have cyst in the kidney.
Ultrasound.
Sir, ADPKD will have
Do you want to concentrate on liver?
yes, ma'am. With ARPKD, there can be liver fibrosis may present, whereas in ADPKD, usually cysts will be seen.
Congenital hepatic fibrosis,
Congenital
portal
hepatic
hypertension.
Most important, you should try to derive it from the family history. So family history becomes very important. Whether only male, whether only female, whether all the parents were, what was the condition in the parents, and whether they were asymptomatic, recessive and dominant. There should be a typical pattern of the history taking. So that will solve your problem, that now probably you are trying to extract whether this pattern of inheritance is dominant or recessive. So whenever you are dealing with this kind of presentation of any genetic disease, you should have explained in this. So definitely these are the some investigations that suggest you associated with this some changes in this biliary tract that will be more in favor of the periportal fibrosis than cholangitis kind of the features, more suggestive of ARPKD. But progressive sclerosis, biliary sclerosis, that is fine. But by taking the history of the inheritance, you should know about whether there is a history of consanguinity. Whenever I have seen ARPKD, most of the patients, we have seen the family of the Muslims having the consanguinity. So that becomes very important. So you should try to extract from the history so that they will know probably you are trying to get it whether this is the recessive inheritance or dominant inheritance, or whether this is the X-linked inheritance.
You said she consumes toddy
yes, sir.
25 years. What is the impact of that
Toddy
on the kidney health, CKD?
on abdominal pain.
That's what I was
Advise her
also.
strongly to stop that, or you say it's okay, chalta hai, let her continue.
No, sir. We have to advise her to stop
What does the literature say about the impact of heavy alcohol consumption on CKD? Does it have any influence on CKD progression at all?
Yes, sir. Alcohol consumption is associated with rapid deterioration in the.
It's not an easy question to answer. There are conflicting reports. Actually, there are initial reports that a mild consumption of alcohol may be of benefit, but now it's fairly certain that heavy alcohol consumption will have a negative impact on chronic kidney disease, because even though it's metabolized by the liver, about 10% of alcohol depends on the kidney for metabolism. In an ailing kidney, heavy alcohol consumption every day in CKD, that will pose a strain on the kidney health.
Have you heard of fetal alcohol syndrome? Mother consuming alcohol during pregnancy, producing fetal malformation.
And low nephron number also.
So, let us just revise your take lessons from this, how to take the history when you are presenting patients from the ADPKD. These are common short cases, and try to prepare yourself before appearing into the examinations.
One small tip is that you should just feel relaxed. If you are a bit stressed, you will not be able to raise vacation.
On 18th of August, informant being self and history being fairly reliable.
Age is how much?
38 years, sir. A patient admitted to the ward for evaluation of renal dysfunction. I would like to date back my history 1 year back when he had developed a headache which was holocranial, dilating, continuous, not associated with nausea and vomiting, not associated with any blurring of vision or diplopia, and it was not associated with any abnormal movement. Patient visited at local hospital, and after a clinical examination, a BP measured and told to have high blood pressure around 190 by 100 millimeter of mercury. Patient was started on antihypertensive medication. Name he remembers as Telma 40 mg. The patient was advised for detailed evaluation for the same, but he did not comply and continued to take medication with poor compliance and poor follow-up with no further BP records. 6 months later, patient noticed swelling of both lower limbs confined below angle, which was pitting in nature, non-tender, not associated with any fever or any discoloration of the limbs. At this time, he did not give any history of decreased urine output, frothy urine, shortness of breath, chest pain, or no history of abdominal distension or yellowish discoloration of eyes. He consulted at local clinic and taken some medication, after which swelling subsided, and he did not do any further follow-up. Intermittently, patient used to notice leg swelling, for which he used to take medication without any doctor's prescription, and no BP recording were available at this point of time. 3 months later, he developed sudden onset breathlessness, that was NYHA grade 4, associated with heaviness of the chest and diaphoresis, and he was taken to the hospital, where he was evaluated and told to have high blood pressure values, and he remembers it as 200 by 100 millimeter of mercury, and he was given some IV and oral medication to control BP, and his previous antihypertensive medicines were optimized, and also at the same time he underwent some blood and urine test, and this at this hospital, and he was told that he is having increased serum creatinine, and that was 2.2 milligram per deciliter, and also told that he is having leaking protein and blood through the urine, for which he needs to undergo further evaluation at a higher center. At this point, he does not give any history of any oliguria or macroscopic hematuria, graveluria or flank pain. There was no history of any rash, joint pain or oral ulcer. There was no history of any loss of appetite, nausea, vomiting or fever. There was no history of dysuria, increased frequency or urgency, or any analgesic use or indigenous medicine use. In between, he has consulted at multiple hospitals during last 3 months, and he was advised for some renal biopsy, which and now he has come to NIMS for further evaluation. At presently on evaluation, he was told to have serum creatinine is around 2.5 milligram per deciliter. A past history, there is no history of any diabetes mellitus, CVA, or any coronary arterial disease or seizure disorder, or no previous infection or history of infection of pulmonary tuberculosis, or there is no history of any major surgical or medical illness in the past. Family history, a patient is born second order, born out of non-consanguineous marriage with married, having 2 children, the elder son around 7 years of age and younger daughter of around 3 years of age, and there is no family history of any hypertension or any renal dysfunction. Personal history, normal. Coming to general examination, is having moderately built, averagely nourished, with pulse rate of 80 per minute, and regular normal volume force and tension, and peripheral pulses were good. No, the BP was around 150 by 90 millimeter of mercury in right arm supine position. There was there was no pallor, icterus, cyanosis or clubbing, and on systemic examination there was no abnormality. Summary, this
On
is
systemic examination, no abnormality.
no sir.
Have you examined cardiovascular system?
Yes, the cardiovascular system is examined. It was normal, with the apex bit felt in the 5th intercostal space, medial to mid clavicular line.
the character of the atrial pulse?
Sir, this pulse width was upheaving type, sir.
Is that an important finding?
Yes, ma'am.
What are the other specific cardiovascular findings you want to look for?
Any carotid bruit or any renal bruit we have to
Cardiovascular examination. Other than apex, what else you are interested in?
any murmur in the apex,
What are the cardiovascular evidence for long-standing uncontrolled hypertension?
presence
You want to know whether this hypertension is long-standing or not, isn't it?
Yes, ma'am. Any left ventricular hypertrophy
That
is
you have
present.
already said. Hmm. What else will you look for? Hmm? You want to look at the intensity of A2?
Yes, ma'am.
Hmm? Other vascular system, are you interested to see the peripheral vasculature and bruits over the peripheral vessels? Why?
Ma'am, in peripheral vascular disease or any
Why that evaluation is important in this patient?
ma'am, a patient is a young patient with hypertension.
This is a hypertension syndrome, isn't it?
Yes, ma'am.
Ah. So,
So
have you looked for bruit over the femorals, carotids?
Just describe the pulse of this patient. Just tell me about the pulse, how you examine pulse and how you describe about the pulse.
sir, for this patient pulse was 80 beats per minute, sir, which was a regular and the volume was normal, force and tension was normal, and peripheral pulsations, all peripheral pulsations were palpable, sir. There
Okay,
was,
what other things are important?
sir, is there any radial or radiofemoral delay is present, sir?
Why that
Or
radiofemoral
pulsation
delay
are
is
equal.
important here?
Ma'am, any discrepancy or any this vasculitis or
Vasculitis.
coarctation of aorta, there will be
Coarctation.
delay will be there, ma'am.
Radiofemoral delay, है ना? So this would be all in the normal volume, normal character, है ना? Number of pulse rhythms. This would come in one line, है ना? No radiofemoral delay. So that you should all explain about this. So that excludes of many of the diseases if you are dealing with the hypertension.
Describe a typical renal bruit in a renovascular hypertension.
Ma'am,
Where will you look for renal bruit and typical characteristic feature?
ma'am, renal bruit will be heard in 1 centimeter, 1 to 1.5 centimeter above and lateral to umbilicus, ma'am.
1 centimeter above one lateral to umbilicus.
Yes,
Ah.
ma'am. It will be continuous.
When will you see such a bruit? That is pathognomonic of renal artery stenosis. What is that? And it tells you that this is a hemodynamically significant obstruction.
When there is obstruction more than 70 to 80% of
Systolo-diastolic bruit, isn't it? Systolo-diastolic bruit is pathognomonic for renal artery stenosis and tells that is the only clinical finding for a hemodynamically significant obstruction. Can you have a renal bruit without a renal artery stenosis? You are getting a systolic bruit in the near the umbilicus, but further evaluation is not showing any significant renal artery stenosis. Can you have that? In which condition? Hyperdynamic, very thin individual.